Good morning, good afternoon, and good evening, dear colleagues, seniors and juniors. Welcome to my Forum for Urology Residents. This is basically for students who are preparing for the urology exams, whether it is MCH exam or the NB exam. Also, for those who are preparing for the entrance, that is the NEET SS or the INI set SS, and it may also be useful for the fellowship exams. And the motive is to sort of cover the theoretical aspects of the textbooks, the two standard textbooks that we have, Campbell and Smith, in a short and precise yet comprehensive manner as much as possible. So, with that message in mind, with that thought in mind, I'll just quickly start today with this topic: genitourinary causes. Diagnosis and management of genitourinary TB. So 8.4% of genitourinary TB patients are asymptomatic. Fever, weight loss, night sweats, and malaise are seen in fewer than 20% of patients. 50% of patients with GOTB have only dysuria on presentation. 50% have storage symptoms. 33% have hematuria and flank pain. Renal colic occurs in fewer than 10% patients, that is, passage of necrotic papillary tissue, clots, stones, and caseous phlegmon. I'm sorry for wasting your time in re-emphasizing on the words and the percentages, but I have done that intentionally because these percentages are very important. 50% patients will have dysuria, 50% will have storage symptoms, 33% will have hematuria and flank pain, and 10% might have colic. And 8.4% will be asymptomatic, while 20% will have fever, weight loss, night sweats, malaise, and constitutional symptoms. Starting with the a plethora of tuberculous manifestations in the genitourinary tract. Prostatic TB. You might encounter this when it's very difficult to diagnose clinically, but a patient with prostatic TB might have nodularity on digital rectal examination, which could be mimicking malignancy. Tuberculous prostatitis, urethritis. These can cause beefy redness and superficial ulcerations on endoscopic examination. Dilatation of the prostatic urethra and prostatic ducts is part and parcel of it, and sometimes diagnosis is made after histopathological examination of transurethral prostatectomy, the TOR CHIPS examination, that is histopathological examination. In fact, the tuberculosis of the prostate may not be diagnosed until it's laid or in the retrospective evaluation. So but it's a good idea to keep this concept in mind. As we know, tuberculosis is the second greatest mimical. After syphilis, it has been called the second greatest mimical of the world. Now, penile tuberculosis can present as an ulcer, clinically indistinguishable from STDs or malignancy. Cavernocytis and cold abscess formation presenting as penile deformity or impotence. Similarly, urethral TB could cause stricture, symptoms, fistula, hematospermia, and so on. Epididymis and testis. Now, epididymis and kidney, these are two hotspots for tuberculosis of the genitourinary tract because of their vascularity and because of the disease pathophysiology itself, how the pulmonary tuberculosis spreads from the primary focus to the genitourinary tract by the hematogenous route. So the infection usually starts from the globus minor, as it has a rich vascularity, usually presents as a painful scrotal mass. Infertility could be a disastrous complication due to this, due to tuberculosis, due to epididymal and or vasal obstruction. Nodular bleeding of the vas and cranky calcified epididymis are characteristic physical findings. Neglected cases may present as total sinus, which is usually posterior. So nodular bleeding of the vas and cranky calcified epididymis. These are the take-home points from this slide. Now, many clinicians have held webinars and have conducted conferences. They have sat together to actually chalk out what we should use in the day-to-day practice as a clinical diagnostic criteria for genitourinary cocks. For genitourinary cocks per se, not for pulmonary TB or any other TB, because as urologists, we are faced with this dilemma as to when to label the patient as COX, when to label the patient as a suspected COX, when to start the patient on ATT. And this dilemma has to be addressed at some point, sooner or later. And the earlier we do it, the better it is, because 1/3 of the world's population of tuberculosis is hosted in India. 1/3 of the drug resistant tuberculosis is hosted in India, and one third of the Indian population has been infected by tuberculosis. So then they came to the consensus that in a clinically uh, uh, case with clinical suspicion, we could use one major and two minor, or two major criteria as the requisite for uh, diagnosis of genitourinary COX. In some circumstances, we can also use just two minor criteria along with strong radiological supportive findings as diagnosis enough to start treatment for tuberculosis. So the major criteria include demonstration of AFB, acid-fast bacilli in urine or tissue, smear or culture, granulomatous lesion in biopsy specimen, and a positive PCR. Minor criteria include IVU, CT, or MRI findings suggestive of GOTB, hematuria, raised ESR, and finally pulmonary changes of old COX. The diagnostic algorithm for extrapulmonary TB, this is according to the NETP or the national guidelines, which have been, which have come out after tremendous efforts of our senior physicians and surgeons who worked really hard to chalk down this algorithm. So in a presumptive EPTB patient, extrapulmonary TB patient, an appropriate specimen from the site is withdrawn. If it is available, then subjected to CBNAT, and if MTB is detected, then we proceed further accordingly. If it is not detected, then we go ahead with cultures and so on, and microbiological diagnoses. And if it's not available, but if we have a high clinical suspicion, then we uh, use microbiological diagnostic tools. That is one option. Two, we can label it as a clinically diagnosed TB, as I just stated. Third, simultaneously, we should keep the possibility of an alternate diagnosis. And after smear, as this algorithm shows, after smear at every point, wherever there's a discordance, wherever there's a confusion, you could go ahead with the culture, liquid culture or the solid culture. And both are, any one of them, if it is positive, it is sufficient to define as microbiologically confirmed extrapulmonary tuberculosis. So why is ESR, the erythrocyte sedimentation rates, elevated in tuberculosis? This is probably an archaic investigation. Very few people really do it, but this is of tremendous value, even though it might not be specific, might not be very sensitive. Actually, it is quite sensitive, but definitely not very specific. But it is still a good idea to know, that ESR is elevated in tuberculosis. It is a good idea to resort to our conventional methodologies and use them and exploit them whenever we can. So ESR measurement is done by Wintrow method or Westergen method. The Wintrow, as you can see, is the first one, and the Westergen is the second one. The diagram itself is self-explanatory. I will not go into the methodologies of these, but whenever ESR is elevated, we all know, we think about tuberculosis, malignancy, and myeloma off the top of our head. So, we think about dysmorphic RBCs, crenated RBCs, and high plasma proteins. It is a non-specific screening test, indirectly measures inflammation of the body, and reflects the tendency of the red blood cells to settle more rapidly. There are three stages: aggregation, sedimentation, and packing. Urinalysis. Now, to do urinalysis for TB, genitourinary TB, the ideal methodology would be as follows. Volume of urine under a cover glass should be at least 0.01 ml. One high power field should examine 1 by 30,000 ml of urine. Bacterial count should be at least 30,000 per ml of urine. Negative urinalysis never excludes less than 30,000 bacteria, and false negative urinalysis could be seen in less than 30,000 per ml count. False positive urinalysis can be seen in lactobacillus and corynebacteria of vaginal flora. So that is one thing that we must keep in mind. Now, the classical feature of tuberculosis is acidic sterile pyuria. Pyuria, by definition, is more than 10 WBCs per high power field in urine. This is a definition that has stood the test of time. And bacteriuria, although not relevant at this point of time, I'll just quickly define it here. It means more than 10 to the power 3 colony forming units per ml, and significant is when it's more than 10 to the power 5 colony forming units per ml in clean catch specimen. and more than 10 to power 3 in catheterized specimen, and more than 10 to power 1 colony forming unit in SPC urine. So, sterile pyuria essentially means a false negative culture due to contamination, recently treated or inadequately treated UTI, renal tuberculosis or chlamydial infections, interstitial nephritis, analgesic nephropathy, sarcoidosis, renal papillary necrosis, diabetes, sickle cell disease, contrast injection, post chemo RRT, urothelial malignancy, and renal stones. Sterile pyuria with microhematuria is seen in 50% of cases. Gross hematuria is seen in 10% of cases, and E. coli infection in 20% of cases. So, how do you collect urine for AFB smear? It should be an early morning, freshly voided, clean catch, whole specimen, which should be refrigerated, and it shouldn't actually be processed immediately, but it should be collected in a refrigerated container. And we need 3 consecutive samples. Why is pH of the urine acidic? Because of mycolic acid in the bacteria. Are there any other mycolic acid producing organism? Yes, Mycobacteria, Rhodococcus, Nocardia, Corynebacteria. How is urine for AFB staining done? Zeal-Nelson staining, and there is Oromine O staining. So in Zeal-Nelson technique, cells in suspension are dropped onto the slide. They're air dried and heat fixed. Then the slide is flooded with carbonyl fission. Then heat fixing. Then we add 1% hydrochloric acid or methanol to remove the excess carbonyl fission, which removes the stain from cells unprotected by waxy lipid layer. And we counter stain with any counter stain like methylene blue or malachite green. So the acid-fast bacilli resist decolorization, hence acid-fast. This is the essence of them, and they appear pink. So what are the other acid-fast bacilli? Atypical mycobacteria, Nocardia, Legionella, volutin granules of Corynebacterium, bacterial spores, fungal spores, in fact, several other fungi, and Cryptosporidium. The traditional way to report has been that if no AFB has been found, they say no bacilli seen. Doubtful, 1 to 2 per 1,000 per 300 fields. If in 100 fields you see up to 10, then 1 plus. If in 10 fields you see up to 10, 2 plus. If in one field you see up to 10, then 3 plus. In one field you see more than 10, you see 4 plus. So easy way to remember is you see one field first. If you see more than 10, 4 plus. If in one field you see some bacteria but less than 10, then you say 3 plus. If you do not see one field but you see in 10 fields, then 2 plus. If you see in 100 fields, then 1 plus. If you see in 300 fields, then doubtful, kindly repeat. So a bacterial load of 5,000 organisms per ml is needed for positive smear. Excuse me. So the South Indian consensus suggested a minimum of 3 samples to be studied, 5,000 organisms per ml to document positivity. At least 8 hours collection of urine is required. Oromine, rhodamine staining with fluorescent microscopy increases sensitivity by 10 to 15%. Smear positivity alone is not diagnostic. It could be positive in Mycobacterium smegmatis. And what are 8 typical mycobacteria? This is not clinician's forte. Definitely not a urologist forte. I'll just quickly run through it because it's something that we should know. The Runyan classification came up in 1959. There are group 1 photochromogens, group 2 scotochromogens, group 3 non-photochromogens, and group 4 rapid growers. So photochromogens or group 1 means they form pigment after exposure to light, like Mycobacteria kansasi, residing in water and animals and causes pulmonary skin, systemic lymph node infections. Group 2, scotochromogens, the pigment is produced in dark, Mycobacterium scrofolaceum. Scrofolaceum scoto, that is probably a way you could remember it. The habitat is water, soil for mites, and it causes cervical lymphadenitis in children. Now, group 3 is non-photochromogens, that is, they do not produce any pigment. Mycobacterium intracellular, Mycobacterium avium, and Mycobacterium xenopi reside in soil, seawater, and animals. Now, they cause pulmonary, GI, renal, systemic, lymph node, pulmonary epidermal infections. And finally, group 4, rapid growers, colonies appear within 7 days. Example, Mycobacterium fortuitum. Habitat, water, soil, and animals. They cause pulmonary, GI, renal, systemic, and lymph node infections. So the strict pathogens are Mycobacterium tuberculosis, MTB, Mycobacterium leprae, Mycobacterium africanum, Mycobacterium ulcerans, and Mycobacterium bovis. So urine for AFB, we've gone through, then talking about culture. So the egg-based culture media, there are a lot of media available. The most popular one that we all are familiar with is the Lovins and Jensen medium, LJ medium. There's pyruvate egg medium and the Dorset egg medium and Petragnani medium, ATS medium. And there is an agar-based culture medium also, that is the Middlebrook medium. To cultivate Mycobacterium bovis, we need to omit glycerol and sodium pyruvate is to be added. This is one really good point that is to be taken home. Major drawback is that it takes 6 to 8 weeks for colonies to appear. That is a major drawback of culture, despite it being so sensitive and specific. So, if you compare egg-based media versus agar-based media, the selective for selectivity, the malachite green is added here, antibacterial and antifungal added here. Rate of growth is slower in egg-based media, faster in agar-based media, and they're able to support ionized resistant and fastidious strains. Contamination is usually less, but if present, it involves the entire surface. While contamination is more frequent in agar-based media. Area of inoculum is relatively small in egg-based medium, while large in agar-based medium. Visual examination is difficult due to medium opacity, while it's clear in agar-based medium, allows clearer colony quantification and morphology confirmation. CO2 is not required in egg-based medium, it's required in agar-based medium. And drug sensitivity testing is not performed on LG in the United States, while on agar-based medium, it is preferred due to larger surface area and faster rate of growth. Shelf life is long, 6 to 12 months of egg-based media, while it's short of agar-based media. So, 3 take-home messages. The rate of growth in egg-based media is slower. Contamination, however, is less. Area of inoculum is relatively small. Visual examination is difficult, and shelf life is long. Lawrence-Jensen medium, LJ medium, as we know, it is the egg-based medium. So it contains several components, and each has a very specific role. Malachite green is obviously gives the color to the media, but it's primarily to inhibit the growth of the other bacteria. Glycerol serves as a carbon source, which is favorable for MTB and unfavorable for Mycobacterium bovis. Asparagus is a source of nitrogen and vitamins for MTB growth. Potato starch is a source of nitrogen and vitamins for MTB growth. And coagulated hens eggs provides a solid surface for inoculation. And finally, mineral salt solution. The original medium used Congo red and malachite green, and this is the Jensen's modification, which eliminates Congo red and uses only malachite green to inhibit growth of other bacteria. Potassium permanganate and magnesium sulfate may also be added. They act as buffers. They enhance organism growth. And asparagus and potato flour are sources of nitrogen and vitamins. So asparagus and potato starch are the main sources of nitrogen and vitamins. Carbon sources glycerol. BACTEC media, BACTEC or BACTEC 460 is a radiometric assay test for MTB with urine and folic acid substrate, that is palmitic or stearic acid, labeled with radioactive carbon. Mycobacterium tuberculosis metabolize folic acid and release carbon. The radioactive carbon is then measured and is a marker for bacterial growth. The major advantage is it takes 2 to 3 weeks for the result, which is a little less than what the culture uses, but still it is quite a long period of time. MJIT. MJIT is mycobacterial growth inhibitor tube. Uses Middlebrook 7H9 broth with oxygen sensitive fluorescent sensor at the bottom. Positive signals are obtained in 10 to 12 days. PCR. Now, PCR may be analyzed even from minute amount of starting material. Sequence of DNA fragment from a few mycobacteria amplified in vitro and the amount of amplified DNA visualized and identified. Results are rapid within few hours of DNA extraction. Sensitivity is 94%, specificity is 88%. DNA PCR doesn't differentiate between live and dead bacilli. However, RNA PCR, since RNA is an integral part of bacterial ribosome, its presence indicates multiplying bacteria and ongoing infection. CBNAT, as we all know, I'll stress on the full form, cartridge-based nucleic acid amplification testing. This is what is being done. Nucleic acid amplification testing is the test, and PCR, polymerase chain reaction, is the principle behind it. And whatever technology we are using is ultimately the proprietary of the different companies. For example, you talk about GeneXpert. Expert is the proprietary machine of SIFI company. which is a big pharmaceutical company. Then we have companies like Roche and others, which have their own machines. But ultimately, what they're all doing is nucleic acid amplification testing. So that is something which we have to understand. These are brand names. These are test names specific to these companies, and these are proprietary materials of these companies. What they perform is nucleic acid amplification testing, and the test or the technique is polymerase chain reaction, which is the three steps which we all know. So nucleic acid amplification testing is highly sensitive and specific with a rapid turnaround time, diagnosis and treatment initiation in the same setting, and they identify mutations in the Mycobacterium tuberculosis genome. They can tell us if the Mycobacterium tuberculosis is drug sensitive or drug resistant, and application of nucleic acid in situ eliminates doubts about contamination. Now, Gene Expert, again, they have, I specifically put this slide here. Now, they have put it as if it's a new test, but ultimately it's a nucleic amplification test. And Expert, when it comes to Expert, it is the proprietary of Cepheid company. It is an automated nucleic acid amplification test, a self-contained cartridge-based test, simultaneous detection of tuberculosis and rifampicin resistance. That is how it came in the initial years. It was automated. It was quick. It gave drug sensitivity testing and resistance values as well. So, and plus it was 100% sensitive on urine samples, but did not require intensive training to use. It gave result in less than 2 hours. Imagine culture media taking about 10 to 2 or 12 weeks. Then some culture media are taking 6 to 8 weeks, and MJIT taking about a couple of weeks, 2 to 4 weeks. Then the MJIT taking about 10 to 14 days, and then molecular diagnostic methods taking hours. So that's how we have evolved in this diagnostic modalities of tuberculosis. And they identify 98% of rifampicin resistant bacilli urine samples. More than 90% of rifampicin resistant strains are also isoniazid resistant. Rifampicin resistance serves as a surrogate marker for multi-drug resistant tuberculosis. Hence, that is why rifampicin resistance is directly labeled as multi-drug resistance. I reiterate, see, if a strain is rifampicin resistant, more than 90% chance is there that it will also be isoniazid resistance. So it is directly labeled as MDR-TB, or multi-drug resistant tuberculosis. Non-sputum specimens such as urine contain natural inhibitors that interfere with the DNA or RNA amplification process, potentially resulting in false negative test results. Tuberculin test. It's all about the person's ability to respond to local concentration of injection, which may be decreased by malignancy, nutritional deficiency, steroid therapy, irritation, and AIDS, or any other immunocompromised state. A positive skin test supports the diagnosis of TB, but a negative skin test does not necessarily exclude extrapulmonary manifestation. This is especially true in cases of genitourinary coughs. Now, moving on. Now, quantiferon TB, gold, QFT GID. Whole blood assay for IgG produced by lymphocytes sensitized to Mycobacterium tuberculosis. It is similar to tuberculin skin testing. It cannot distinguish between prior or active infection. May indicate likelihood of infection. IGRA is interferon gamma release assay common, and it cannot distinguish between active tuberculosis and latent tuberculosis. And it basically tests for antigens like ESAT6, CFP10 present on the MTB. Biochemical markers include adenosine deaminase activity, ADA, and amino hydrolase that catalyzes deamination of adenosine to inosine. Biological activities related to proliferation and differentiation of active lymphocytes. HPLC, high performance liquid chromatography. It's based on the observation that each MTB produces a unique set of mycolic acids. It can distinguish more than 50 such MTB species. However, cannot distinguish between MTB and MBOVIS. MTB and MBOVIS. Niacin test and nitrate reduction test, that is one way to distinguish. Then MTB and NTB, aryl sulfatase test, and catalase peroxidase test. Virulent and non-virulent strains, neutral red test. This is a very good table that we must by heart by now. Moving on to imaging for genitourinary coughs. So what do we see here? We see a dilated pelvic calyceal system, non-communicating calyces, thinned out parenchyma. This pelvic calyces with thinned out parenchyma, non-communicating calyces will obviously open a plethora of possibilities. So at this juncture, we should just keep in mind that somewhere down the line, genitourinary coughs could be a possibility, but there, this will not diagnose genitourinary COX. Moving on. So, what are the ultrasound findings of GeoCox? If, if we are asked at some point of a learning sake or examination sake, in the early stage, it may be normal kidney, or there may be small focal cortical lesions with granuloma with or without calcification. In the progressive stage, there are echogenic masses with distorted parenchyma, irregular hypoechoic masses connecting to PCS, no renal pelvic dilatation, echogenic foci or calcification in bladder wall near the ureteric orifice. And at the end stage, it is a small shrunken kidney, thick normal parenchyma, and small fibrotic thick walled bladder. And as we all know, the end stage is the thimble bladder. What are the limitations of the ultrasound? It is less sensitive than CT in detection of calyceal, pelvic, or ureteral anomalies, isoechoic parenchymal masses, small calcifications, small cavities that communicate with collecting system. The earliest finding, however, if picked up, it's a really helpful finding of an ultrasound, that is a cortical granuloma. What about high resolution ultrasound? Can it help us? Yes, as seen in figure A, small irregular caseous cavity, white arrow. Figure B, tuberculous cavity with fine septae within. Figure C, irregular sonolucent cavities with semi-solid echo texture. Now, caseation with different phases of destruction. Lower group calyces completely merged with parenchyma. Mid group calyces about to merge. Upper ones almost merged. Densely calcified kidney, acoustic shadowing, completely obscuring details of the kidney. A primary use of ultrasound in genitourinary TB is to follow hydronephrosis in patients who are receiving medical treatment, because fibrosis during healing can worsen urinary obstruction. Cystic lesions with septation suggest chronic infection. Restriction of renal movement during breathing suggests a perinephric or psoas abscess. Tuberculosis involving left epididymis and spermatic cord has been shown here for the purpose of learning what could be the imaging findings of tuberculosis. Grayscale sonogram in the first figure shows swelling and heterogeneous hypoechogenicity of left epididymal tail. Then power Doppler sonogram shows increased vascularity in swollen epididymis. Then grayscale sonogram shows swelling and hypoechogenicity of the left spermatic cord. Similarly, what about prostate? So tuberculous prostatitis, in the first figure, this is a grayscale sonogram showing a hypoechoic nodule in peripheral zone, which could really mimic malignancy. Tuberculous prostatitis in the second figure, there's a color Doppler sonogram showing hypervascularity in the same nodule. Tuberculosis involving the seminal vesicle and vas deferens. Grayscale sonogram shows dilatation and wall thickening of the seminal vesicle. Plain X-ray. Plain X-ray demonstrate calcification in more than 50% cases. So that's a startling sign itself. Something so basic, something so conventional, and something yet so informative. That is the essence, the beauty of the medicine and its methodical approach. Then, sorry for the digression. Initial faint punctate calcifications within the parenchyma progresses to globular calcifications. Papillary necrosis appears as triangular ring-like calcifications in the collecting system. With fibrotic autonephrectomy, a small shrunken calcified cement or putty kidney is seen, in which calcific rims outline the individual renal lobes. This lobar pattern is pathognomic for end-stage renal tuberculosis. In figure A, abdominal radiograph demonstrates extensive calcifications forming a cast of the kidney and the ureter. Figure B shows complete replacement of the normal kidney by inflammatory debris. Then there's a plain radiograph here revealing classic lobar pattern of calcification, which is pathognomic of end-stage renal tuberculosis. Ureteral calcification is also noted. Renal and ureteral TB infected calculi. Stones may take strange shapes as they form in a deformed and fibrosed renal pelvis. Upward arrowhead stone indicates a renal pelvis that has been hiked up by contraction and scarring. Intraluminal ureteral calcifications. Bladder wall calcifications are seen in late stages of bladder contraction. Calcifications of the prostate and seminal vesicles are seen in 10% cases. The surrounding tissues changes like erosions of vertebral bodies or calcifications and cold abscesses or the psoas muscle. What about IVU? How can it help us? It assesses the extent of and the severity of the involvement. It helps to monitor the response to treatment, to look for complications. More than 70% of cases, a single kidney is involved in IVU, which may be abnormal in 85 to 95%, 90% cases, the normal in initial stages. Diagnosis can be made with certainty on urography only if the lesion is ulcerated into the calyx. So what happens in IVU, and why certain specific and classical signs of tuberculosis are seen in IVU? There is parenchymal scarring. There's irregularity of the papillary tips, which is seen as called as moth-eaten calyces. Then there are small cavities in the papillae which communicate then subsequently with the collecting system. There's a fibrotic reaction that develops stenosis and strictures of the calyceal infundibula. Infundibular strictures can lead to localized calyctasis or phantom calyx. And finally, scarring of the renal pelvis to give what is called as a Kerking. So this is a fuzzy or a feathery calyx, a beautiful excretory urography showing the classical fuzzy feathery calyx. And yes, moth-eaten calyces can also be appreciated here. The figure B shows a moth-eaten calyx very well. Blunted calyx can be seen. So what exactly is moth-eaten appearance? Earliest abnormality, an indistinct feathery outline, it is essentially an irregularity of the surface of one or more papillae or calyces with normal renal size and contour. It is fuzzy and irregular calyces due to papillary necrosis. On IVU, collecting system shows contrast material in a large papillary cavity, the golf ball, with blunted calyx, the T is adjacent. So this is a golf ball on T appearance. This is the Kerking, the classical Kerking, you can see here. Multiple infundibular narrowing, decreased nephrographic opacity and non-filling of the collecting system elements at the lower pole of the left kidney, phantom calyces. So ghosts exist but not visualized. The same are visualized on RGP. So we have now, we can enumerate and we can also understand, not just learn or mug up the findings of excretory urography or IVP or IVO, intravenous urography or intravenous pyelography. So it could be, the earliest feature is, come on. So yes, so the earliest feature is the blunting of calyces, and then you might find moth-eaten calyces, then phantom calyx, then Kerking, multiple infundibular narrowing, and golf ball on T appearance. And essentially, this is all the signs that we have to remember, but more than remembering, it's the understanding of it. And then there's a hiked up pelvis, which is cephalic retraction of the inferior medial margin of the renal pelvis at the UPJ. As we can see, there is cephalic retraction of the inferior medial margin of the renal pelvis at the UPJ. Kerking is a cortical scarring with dilatation and distortion of adjoining calyces, coupled with strictures of the pelvic calyceal system. So there are strictures of the pelvic calyceal system. Along with that, this cortical scarring and along with that, this dilatation, along with that, this distortion of adjoining calyces. So many things happening together: strictures of the calyceal system, distortion of calyces, dilatation of calyces, cortical scarring. This causes luminal narrowing either directly or by causing kinking of the renal pelvis at the UPJ. Sawtooth appearance is seen in the ureter, the ulcerations causing mucosal irregularity of ureter. Pipe stem ureter is a classical or old pipe stem ureter. Beg your pardon, is a classical description of a geocox ureter. It's a rigid ureter that which shows irregular, mobility and peristaltic movement. Of course, lacks normal peristaltic movement, and fibrotic strictures are noted. Here we can clearly note the distortion, amputation, and irregularity of the upper calyces. Autonephrectomy. Autonephrectomy occurs in 33% of GUTB cases, while end-stage renal disease occurs in 7% of GUTB cases. So after autonephrectomy, there is This kind of picture that we see with the calcified kidney, this is a putty kidney. This is the end stage of GOTB. This is defined as a diffuse, uniform, extensive parenchymal calcifications forming a cast of kidney in autonephrectomy. CT does have disadvantages. CT is less sensitive for detecting the minimal urothelial thickening, subtle papillary necrosis, and other changes of early renal TB, for which IVU is still the preferred study. CT imparts a higher radiation dose than IVU. Anyhow, CT does have an important role, and we cannot miss our discussion without talking about CT and stool tuberculosis. It has been replacing IVU, not only GOTB, but essentially in genitourinary imaging altogether as a modality of choice for practically all conditions. It is equally good at identifying calyceal abnormalities, infundibular abnormalities, renal parenchymal destruction, hydronephrosis, hydroureter. It also identifies adjacent adrenal, retroperitoneal, prostatic, and seminal abnormalities. Now, as we can see here, this perinephric, periureteric, pelvic events, with all these things are identified with a high degree of accuracy in CT, the CT urogram. A well done CT urogram with all the phases is the single investigation that can give you everything about and diagnose tuberculosis, obviously in the light of clinical findings. That's all you need. So CT, KOB, the IVU, the first is the nephrographic phase. Even before that is the corticomedullary phase. So the nephrographic phase, we appreciate dilated calyces, thinning of renal cortex, thin calcifications. Then we see caseous tuberculous cavity in the upper pole of the left kidney, pointed out by the arrow, in the axial tomography film, and also the reconstructed coronal film. Until the parenchymal lesion communicates with the PCS, it is likely to get missed out in the IVU. So no non-functioning hydronephrotic right kidney. Yes, that is also a big finding here, rather a bigger finding here. I'm sorry if I forgot. I wanted to stress on one point. I digressed from the bigger picture here. So that again reiterates the importance of looking at the cross-sectional imaging from all the aspects. Now here is demonstrated a left subcapsular urinoma. It's a very good axial computer tomography film showing all the signs. Almost the black arrows here suggest site of rupture into the perinephric space. Sorry, the black arrows here suggest the bending changes. But essentially, you can not miss this. You cannot miss this finding of subcapsular urinoma. Renal abscesses, yes, renal abscesses will be finding tuberculosis and easily picked up on computer tomography because of perinephric spread, psoas muscle involvement, and fat stranding. There are multiple findings in the left tubercular renal cavity, like no pelvic dilatation, parenchymal scarring, cavity communicating with the PCS, urothelial thickening, and multiple ureteric narrowing. This is a classical picture of genitourinary cox. You might not get the classical picture every time, but since the particular case demonstrates that, so I enlisted all the findings and stressed upon them. So a CT urogram is using curved multiplanar reformation, helps the urologist to easily, and especially beginners, to easily identify pickup signs. For example, here we can see massive gross pelvic calictasis, gross hydronephrosis, multiple dilated calyces communicating with each other, with thinned out renal cortex, with limited functional renal parenchyma probably. With renal contour or reniform shape, all disturbed. Multiple ureteric strictures at various sites. Calcifications also noted. So here, the take-home message would be severe non-uniform calictasis and multifocal strictures involving renal pelvis and ureter. MRI in GOTB is not commonly preferred because CT tells everything, to be honest, and we don't usually require it. And MRI, secondly, is not is a much more expensive investigation. For a developing country like ours, it might not be, the cost factor is there, the feasibility is there, logistics and all. And apart from that, it's not a good investigation to pick up calcifications. Mm, and uh, it needs an expertise, whether an expert urologist or a radiologist to contemplate the films. Usually, urologists are more comfortable reading CT films. So, but however, it gives equally good detailed and required information. It is done when there's compromise in the function, pregnancy, and allergy to contrast media. These are the only indications of MRI in practical aspect. Uh, Otherwise, CT gives more or less all the information. Nevertheless, it's a good idea to know what MRI tells. MRI can detect a single granuloma. Small lesions are hypointense on both T1 and T2 images. Larger lesions have central hyperintensity on T2 with increased cellularity at the center of the granuloma. Larger TB lesions can mimic malignancy. MRU can be more sensitive than IVU in showing urothelial thickening and cholestasis. Cine MRU and dynamic MRU can evaluate urethral peristalsis. Diffusion weighted imaging can help distinguish hydronephrosis from pyonephrosis. Diffusion weighted imaging also can be used to monitor renal fibrosis. Apparent diffusion coefficients, ADCs, decrease with fibrosis and can be used to gauge the stage of TB, including the efficacy of treatment. So this shows an MR film depicting tuberculosis involving left epididymis and spermatic cord. Oh my God, that's something which a urologist might find very difficult to read. T1 weighted images show a left epididymis and spermatic cord swollen. This is tuberculosis involving the left epididymis and spermatic cord. This is still easier to read because of the gross findings. These are T2 weighted images, yes, with internal low signal intensity on T2 weighted imaging showing chronic inflammation fibrosis. Tubercular prostatitis causing abscesses, which was drained and treated with ATT, has been demonstrated here. First, a grayscale sonogram shows low echoic mass replacing prostate with post enhancement of mass, suggesting a properly liquefied uh, prostatic abscess. A T1 weighted MR image shows swelling of the prostate, internal low signal intensity. T2 weighted MRI shows low signal intensity surrounding high signal intensity. On gadolinium enhanced T1 weighted imaging, area of low signal intensity on T2 weighted imaging shows enhancement, implying a wall of abscess, as pointed out by the white arrowheads. Retrograde and antegrade pyelography, there are two indications for it. One is urethral catheterization to obtain urine sample for culture for localization of disease and to delineate the stricture length of the ureter. These are two precise indications. The indications can be elaborated further actually, but these are two indications that we must know. Percutaneous antegrade access is required if antegrade access is unachievable or insufficient for drainage of the kidney. It also provides a route for obtaining urine samples from the renal pelvis or tuberculous cavities for culture and to assess therapeutic drug concentration at the target sites. Cystoscopy and bladder biopsy are rarely indicated. I'm sorry, actually, I do not agree with the statement in entirety. Cystoscopy is indicated, but not bladder biopsy. Cystoscopy will reveal um, a whole lot of information from starting from inflammation to reduce bladder capacity, patulous urethral orifice. But yes, we have to be careful. It carries a high chance of perforation. It is diagnostic of GOTB in up to 46% of cases. It is done if there is suspicion of associated malignancy. As per the Gazette notification of the Ministry of Health and Family Welfare, dated 16th March 2018, clinical establishment, doctors, laboratories, pharmacists, chemists, druggists that fails to notify tuberculosis patients will be booked under sections 269 and 270 of the Indian Penal Code that carries a jail from 6 months to 2 years or a fine or both. This is to reiterate that we must send the patient to DOT center where the notification can be done, or we must be in continuous communication with the nodal officer and the DOT center all at all points of time. It is a notifiable disease, genitourinary cocks. Moving on to medical management quickly. So, way back in 1925, published in American Journal of Public Health. Senochrysine was proposed as a gold cure for tuberculosis. It contained sodium orothiosulfate. The point of putting it here is to suggest how far we have gone. We have completed 100 years, 1925 to 2025. Today we have sophisticated treatment modalities, sophisticated algorithms, and everything. So the first agent used as an anti-tubercular drug was streptomycin. Subsequently, the first line anti-TB drugs were sulfonamide, but since sulfonamides are bacteriostatic, resistance occurred rapidly. So the second agent that was tried was dapsone. It was though effective, but in long-term therapy, it was found to be toxic, so it was discontinued. In TB treatment, major breakthrough was the development of streptomycin in 1944, an aminoglycoside that was highly effective against MTB. Afterwards, many synthetic drugs were developed to eradicate TB. Despite such developments, it is still prevailing due to emergence of multi-drug resistant strains. So the first line is HRZES, HRZE actually is what we must focus on. Isoniazid, rifampicin, pyrazinamide, and ethambutol. The second line drugs are ethionamide, cycloserine, tazodone, then para-aminosalicylic acid PAS, rifabutin, and rifapentin. I repeat, ethionamide, cycloserine, tazodone, para-aminosalicylic acid, rifabutin, rifapentin. Third line drugs are fluoroquinolones and injectables. Moxifloxacin, levofloxacin, ofloxacin, ciprofloxacin. Injectables include capreomycin, kanamycin, omecracine. The newer drugs have, whether you call it fourth line or whatever, there's no terminology is fourth line, but new drugs are an essential treatment of tuberculosis today, especially the drug-resistant varieties. Bedaquiline, dilamanid, and pritomanid, PA824. Bedaquiline, dilamanid, and pritomanid. We cannot just do away without them. So isoniazid, the drug formulation is 100 mg, 300 mg tablets, or 50 mg 5 ml syrup, and 100 mg per ml injection. The daily adult dosages we can remember as HRZE. So H is 5 milligram per kg, maximum 300 mg. R, rifampicin, is 10 mg per kg, maximum 600 mg. Z, pyrazinamide, is somewhat 25 to 30, but it's weight based. 40 to 55 kgs is 1000, 56 to 75 kgs is 1500 mg, 76 to 90 is 2000 mg. Ethambutol is 5 to 10, again about 10 mg per kg. So it comes out to be up to 55 kgs 800 mg, to 75 kgs 1200 mg, up to 90 kgs 1600 mg. So this is the daily adult dosing. Intermittent dosing, I would not be talking about it because we are following the daily regimen. The adverse effects is something we cannot just ignore. Actually, it's the first thing that you should be knowing about these drugs. Isoniazid carries hepatotoxicity and peripheral neuropathy. Rifampicin carries hepatotoxicity, flu-like syndrome, pleuritis, and drug reactions. In fact, drug reactions is the biggest nuisance of rifampicin. It is a strong cytochrome P415 user, which actually we come to know, which comes to light when we treat HIV and TB patients, or patients who are taking immunosuppressives and anti-tubercular drugs and so on. So rifabutin again carries hepatotoxicity, flu-like syndrome, uveitis, neutropenia, drug interactions. Rifapentin is similar to rifampicin. Pyrazinamide, arthralgias, hepatotoxicity, pleuritis, rash, hyperuricemia, gastrointestinal upset. Ethambutol decreased red-green color discrimination, decreased visual acuity, and optic neuritis. Streptomycin causes vestibular and auditory toxicity and renal damage. Capreomycin causes auditory and vestibular toxicity, renal damage, electrolyte imbalance. Kanamycin, ototoxicity, renal damage. So that's common to all aminoglycosides, ototoxicity and nephrotoxicity. Cycloserine, ceromycin, causes psychiatric symptoms, seizures. Ethionamide causes GI toxicity, hepatotoxicity, hypothyroidism, optic neuritis, neurotoxicity. Levofloxacin, GI toxicity, CNS effects, QT prolongation, tendinitis, tendon rupture, rash, and dysglycemia. Moxifloxacin has the same profile. PAS becomes a passive aminosalicylic acid causes GI disturbances, more or less, like mild acute hepatitis. Linezolid causes bone marrow suppression, hepatotoxicity, peripheral and optic neuropathy. Bedaquiline causes headache, nausea, arthralgia, QT prolongation, and hepatotoxicity. So, monoresistant TBs or TB patients with biological specimens is resistant to only one first line anti-TB drug. So it means TB patient who is resistant to only isoniazid, because rifampicin resistance would automatically go as MDR resistant. Rifampicin resistance, as we see, a TB patient whose biological specimen is resistance to rifampicin detected using phenotypic or genotypic methods with or without resistance to other anti-TB drugs. So it includes any resistance to R in the form of mono resistance, polyresistance, MDR, or XDR. And multi-drug resistance is a TB patient whose biological specimen is resistant to both isoniazid and rifampicin with or without resistance to other first-line drugs. MDR TB patients may also have additional resistance to any or all the fluoroquinolones or any or all second-line anti-TB drugs. Extensive drug resistance is XDR. By definition, is an MDR patient whose biological specimen is additionally resistant to a fluoroquinolone and a second line injectable. So, the correct categorization is important. Tubercular patient, whether just like pulmonary COX and geocox patient, a new case, previously treated case with relapse, failure, treatment after uh, failure after the previous treatment or loss to follow up and so on was put to category 1. Then MDR TB is put to category 4, XDR is put to category 5. New or previously treated patients, whether it's relapsed, whether it's failure, treatment after loss to follow, intensive phase of HRCD2, and continuation phase of 4, a total duration of 6 months. For drug resistant TB, the intensive phase involves 6 to 9 months of levofloxacin, kanamycin, that is one fluoroquinolone, one aminoglycoside, and ethonamide, cycloserine, pyrazinamide, ethambutol. And the continuation phase involves levofloxacin, ethonamide, cycloserine, and ethambutol. Total duration is 24 to 27 months, 6 to 9 plus 18. For XDR, the intensive phase is 6 to 12 months of high dose moxifloxacin, capreomycin. There we use levofloxacin and kanamycin. Here we use, in addition, ethionamide, cycloserine, pyrazinamide, ethambutol, linezolid, and so you can really appreciate, the amount of drugs that we are taking the patient to. We might have to add terizidone also to here, and followed by 18 months of continuation phase of moxifloxacin high dose. There's also a shorter MDR regimen, that is rifampicin resistance with isoniazid sensitivity or unknown. So here we give 4 to 6 months of high dose moxifloxacin and kanamycin with ethonamide and pyrazinamide, isoniazid, ethambutol, along with ethonamide and cycloserine or linezolid or terizidone, and followed by 5 months of moxifloxacin and so on. So bedaquiline or Certuro was the first new drug in 40 years. It was FDA approved in 2012 to treat multi-drug resistant TB. Side effects include nausea, joint pain, headache, and hepatotoxicity. Dose is 400 milligram once a day for 2 weeks, 200 milligram 3 times per week for 22 weeks. It is a diaryl quinolone that targets mycobacterial ATP synthase. I repeat, mycobacterial ATP synthase. It is a strong bactericidal, no cross resistance with first and second line ATD. It's a wonder drug, and it's for adult aged 18 years or more having pulmonary MDR TB and females who are not pregnant. Effective against both dividing and non-dividing bacteria, and extensive tissue distribution of up to 5.5 months per. Delaminid and pretomanid, that is PA824, many experts have started using them, although they are in trials. They're active against and replicating and hypoxic MTB, and they may be also useful against non-replicating MTB. They're bactericidal with half-life of 36 hours. They're the first approved 2014 drug in the class of nitrohydroimidazole, uh, nitrohydroimidazole oxalones for the treatment of MDR-TB. Delaminate may have a protective role in preventing the emergence of additional drug resistance. Delaminate 100 milligram, two tablets, 50 mg each, given orally twice a day for the first 24 weeks is the policy that is usually followed. DOTS is our country's greatest work, and a lot of hard work has gone by, you know, bureaucrats, politicians, physicians, surgeons, all the medical staff, right from the ASHA worker to the ANM and everyone. So it's a very systematically arranged program to ensure cure, to ensure provision of medicines free of cost, to confirm that it's taken. We must appreciate this because we are a developing country where compliance is poor, literacy is poor, and sometimes patients just don't understand the uh, aggressiveness of it, the probable sequelae of it, the probable seriousness of it, or and they are the innocent sufferers, or some may not be, and the rest of them are not able to tolerate or take the pills because of pill burden, or various other factors because of the toxicity and so on, and they may not be able to recognize it. That is one. Second, they may not be able to report them. That is two. Third, they may not be able to reach the appropriate health center. And finally, they might just feel embarrassed and just keep it to themselves. So in our country, it's a big thing. So there's an intensive phase and a continuation phase. And what they have done is a tremendous work. They have introduced fixed dose combinations. They follow up patients, and they have ensured high cure rate, decreased drug resistance, adverse drug reactions are monitored. So, is there any role of steroids? Generally not indicated. High dose prednisolone, that is 20 milligram TDS for 6 to 8 weeks, can be given in severe bladder symptoms or involvement of tubular structures like ureters, vas deferens, fallopian tubes. Yes, again, rifampicin, the culprit, or the gold or the key player in every scenario, comes again. It reduces the bioavailability and effectiveness of steroids by 66%. This we should all keep in mind. Steroids are definitely indicated in two conditions, that those are TB meningitis and TB pericarditis. That's undisputed. Monitoring for tuberculosis relapse. GUTB patients may relapse at a higher rate than pulmonary tubercular patients, up to 22% of cases, even after 12 months of medical therapy. Difficulty in achieving complete sterilization of all foci may be the reason for higher relapse rate. And GUTB patients are recommended 10 years of follow-up because of the average time of relapse being 5.3 years. And the recent changes in TB management, actually they change so quickly that you have to be updated every day. And this is just a short list, this is too short to enumerate all of them. But there are numerous changes in the recent management of genitourinary cord, especially. Category 3 of RNTCP has been abolished in 2010. Introduction of CBNAT gene export for TB diagnosis in 2010. Ban on serological testing for TB diagnosis in 2012. TB declared as a notifiable disease in 2012. Category 2 abolished in 2018, specifically December 2018. So this category 1, category 4, category 5. There's no category 2, 3. Withdrawal of kanamycin from H mono poly drug resistant TB regimen in 2018, and non-declaration of TB made punishable in 2018. Daily regimen introduction 2016. Thank you.